Good afternoon, everyone, and welcome to CMSNE's Lunch and Learn webinar, collaboration between inpatient and outpatient teams for medically complex pediatric patients. My name is Maureen Ferguson, and I welcome you to the event today. I just want to go over a few housekeeping details very quickly. I always have trouble advancing my slides. I'm sorry. There we go. I'm not going to go over these in great detail as it has been in the rotating slide deck. If you're not seen by anyone or and you have been muted for the session, please use the Q&A box at the end of the screen, at the bottom of the screen, to enter any questions you may have. When you leave today, please leave by the red end button, and that way you will go to the page where you will get the evaluation link. Be sure to include any information that is requested from you. One important thing I want to make sure today, CMSNE's policy of no AI recording or note taking can be done. It's strictly prohibited. It's now my pleasure to introduce to you June Stark, who will do some updating on chapter business. June?
Thank you, Maureen. Welcome, everybody, to our second Pediatric Special Interest Group webinar. We're really excited, the chapter, to be able to start this new series of education for pediatric case managers, as well as other case managers that are interested. This endeavor, educating pediatric case managers, is part of our goals and will be threaded through educational programs offered throughout the year. So this is the Case Managers Society of New England, CMSNE, which is a chapter of CMSA, Case Management Society of America. Both the main organization and ourselves are the oldest running organizations and chapters for case management in the country. And because of that, that gives you a lot of advantage if you participate and become a member. Because of our longevity, we have established practices and educational programs that you can, and standards of practice too, that you can take advantage of. So we want to welcome you today, not only to this presentation, but also to consider, if you're not a member, to become a member. So membership to CMSA and CMSNE is really interdisciplinary and multidisciplinary. So anyone who is active as a caregiver or has another role in case management can apply for management. It's not just the professional staff, it's really any staff member that is involved with case management care of patients and families. So what are some of the advantages to you? Here they are listed on this slide, although there's many more, but these are the main ones. First of all, you're going to have access to professional CEUs as well as CCM CEUs for those of you who are certified. And you're going to have exposure to those and access to those on a regular basis. The main organization, CMSA, has over 100 free educational programs that you could access online once you become a member. As well as we too, our chapter, has a library on our website that you can access. And I invite you to take a look at our website. It's been upgraded and it offers a lot of benefits to you, member or non-member. The next advantage is that you have all these networking opportunities with case managers that are like you or case managers that are doing work that you're really interested in and want to expand your understanding. It supports your own professional case management growth. It gives you access to chapter relevant news in real time, which is really important because we're increasing our educational programming and you want to stay on top of that because our educational program is current and meeting the really the acute needs now of case managers. And then we also, our chapter has a scholarship um, advantage that you could apply for. And so that's just some of the benefits. Next slide, please, Maureen. So membership for national is $170, and for the chapter, it's an additional 35 for a total of 205. And our membership committee has actually calculated that the cost of membership is equal to about 4 cups of coffee, of course, coffee that you purchase outside your home in a month. It's equal to that. But I take advantage of another opportunity that CMSA has offered us, and that is a easy pay or a flex pay. And you could, when you join, you could sign up for this payment plan, and it's about $15 a month. And I do it, and it automatically comes out of my checking account or my Visa account, and it's $14.66. And it's really worth it with all that you get. Okay, next slide, please. So the chapter has started this year to put out a calendar of educational events. You can see it here. And it's accessible online at a website. And I believe Maureen's going to make that available to all of you that are here today. And what's important about the calendar is that we're updating it in real time. And so it's not like you get a calendar for the year and we do something new and you might miss it because it's not on the calendar. You actually could use this calendar so that you're prepared and able to request time if you need to attend educational programming from us. The next special pediatric special interest group is Wednesday, July 16th. Please don't miss it. I know it's summer, but summer is a great time for learning too. And we're really happy to announce this, that Ellen Fink Samnick, you might know that name. She's nationally and internationally known. She's a high award winner social worker for her ethics, lecturing, and publishing. So that's coming up. So keep an eye for that. And if you haven't registered yet, please consider that. Another save the date is up here, well, up by you, I should say, in Portland, Maine. The annual CMSNE conference is going to be held at the Elks Lodge. So that's a great opportunity. We held it up here last year and it was a great event. All right, what's next? Please, next slide. So I want to give special thanks to our educational committee that formed our first 3 SIGs: Jennifer Boone, Jen Amadon, Bonnie Busma, Mary McNulty, and myself. Next slide. Special thanks to our sponsors. We really need to recognize our sponsors because they help to make today possible. Our virtual sponsor is Core Health, and Adapt Health will be giving you a presentation in about 1 minute. Core Health, this is information on that. It's going to be in your packet. And so please take a look at that. It's pediatric nursing services targeted at pediatric patients needing case management. And with the next slide, I'm going to introduce our speaker for Adapt Health, Pediatric Ventilation. Our speaker is Michelle LaValle. She is the Vice President of Advanced Clinical Care. And with that, welcome again, everybody, and I'm turning it over to Michelle. Thank you.
Okay, thank you, everyone. Hopefully you can hear me okay. I'm actually sitting in a hotel room in Seattle at the sleep conference, so all good things are happening today. So Maureen, thank you so much. I'm guessing, do you want me to share or are you going to just go ahead and advance the slides?
I can advance if you want me to. It's easier.
Oh, okay, perfect. All right, guys. Well, thank you again. We really appreciate the opportunity for us to tell you a little bit more about Adapt Health and what we do. So kind of to kick it off, as you are told, I'm Michelle LaValle. I'm our Vice President of Advanced Clinical Care. I actually manage our home ventilation program for the adult and pediatric patients that we service. So for us, we're really proud. We're actually one of the leading providers of personalized medical equipment and supplies. Our goal is really to help patients thrive in their home and not in the hospital. We want to get them home where they're feeling great and keeping them healthy. We bridge the gap between patients and their health providers, ensuring high quality, seamless care where it matters the most. We work with all kinds of providers, from women health providers, practice groups, pulmonary specialists, wound care clinics, sleep labs, and of course, clinics and diabetes and respiratory. So Maureen, you can advance to the next slide, please. So for us, we actually deliver and we scale all kinds of equipment, technology, and service excellence to help achieve our patient goals. We have a nationwide reach, which is one of the largest full service suppliers. We offer a broad product availability across the entire United States. We'll talk about that on the next slide here in a minute. One of the things that we have been really focused on in the last few months is advanced technology. We have innovative tools and services that really enhance the patient experience, streamline operations, and improve outcomes. We've launched just recently a new app. It's called My App. That application actually helps our patients with self-scheduling of services, such as oxygen tank deliveries. They can contact customer service if they need help through a chat. They can get information on billing. So there's a lot of great things that we have up and coming with our My App. In addition to that, we have flexible partnerships through value-based care services models, really designed to help reduce costs and provide financial predictability in the market. All right, Mari, we can go to the next slide. So this is one that we're really super proud of. It's the products and services. So our products and services are extensive. So we are a full service DME. We currently serve over 4 million patients across the country. We have an extensive reach. So we have multiple locations. As you can see, we have 674 locations and growing, which is fantastic. Means we can help a lot more patients. We make about 38,000 deliveries per day and have over 2,800 insurance contracts in place to meet the needs of our patients. We do provide high quality products, everything from ventilation, oxygen therapy, of course, sleep therapy, diabetes in the form of CGM and supplies, insulin pumps, and of course, our standard DME, ostomy supplies, breast pumps, orthotics, and wound care. So again, everything that you could possibly imagine, we probably do carry it. All right. So moving on, Maureen, we can go to the next slide. So our brand promise at Adapt, we want to place our patient first always, whether that's from safely delivering equipment, set up through ventilation, but we have specialized teams in place. Our teams collaborate to ensure consistent, high quality care across every stage of the patient journey. We feel we go above and beyond, from an equipment standpoint. We deliver comprehensive medical equipment that's patient-centered. We want to make sure that experience is positive. We specialize in that commitment to compliance and advice adherence so the patient can benefit from the therapy that their doctors are prescribing. We also have proactive and timely interventions with our patients. And one thing that we really, really love to focus on and talk about is just our outcomes. Driving positive outcomes, caring for our patients is something that all of us as healthcare providers is so important, especially in the home, as we can be eyes and ears and as an extension of care for all of you. And again, just that extension of care for our referral, our partners, all of you, we want to help bring that trusted care directly into that patient's home. And then the last slide, Maureen, if we can advance to that one, please. As we talk more about pediatric ventilation, and hopefully we can get a chance to do the whole presentation and focus on this, we just want to talk about some of our clinical goals. It's pediatric, it's adult, But basically, our approach is really designed to support better outcomes for our patients, their families, and of course, our healthcare partners. We want to focus on reducing hospitalizations and readmissions, enhancing quality of life, improving dyspnea, and reducing the overall work of breathing for our patients in this patient population. Of course, delivering the right therapy at the right time. And by doing that, I mean, obviously with our extensive list of products that we carry, we can certainly partner with you to do that. And of course, streamlining that referral process. We want to make that process easy for our physicians, for our case managers. So when you're sending us a referral, we want to collaborate, communicate, and make that process as seamless as possible. So hopefully I didn't go over the time. I'm trying to keep it within our time restrictions here. But again, would love to speak more about our extensive program on ventilation and specifically pediatric ventilation. And again, we thank you so much for the opportunity for us to tell you just a little bit more about Adapt Health and the services that we provide.
Thank you very much, Michelle. That was excellent. We're now ready to start our program. And the title, of course, is Collaboration Between Inpatient and Outpatient Teams for Medical Complex Pediatric Patients. And I'm turning it over to Amanda Payne. Thank you, Amanda.
Thanks, June. Hi, everyone. Good afternoon. I'm going to start by introducing our speakers. My co-presenters and my lovely colleagues today, starting with Bonnie Boomsma, who is in this group, so a lot of you may know. Bonnie is an employee at Maine Health Barbara Bush Children's Hospital, and she is one of the registered nurse care managers. Dana Orkin works with Bonnie on Barbara Bush, and she brings 15 years of pediatric inpatient nursing experience to this new role of pediatric complex care navigator. Myself, I'm going to throw my introduction into myself in the middle here. My name is Amanda Payne. I'm a nurse practitioner, and I am employed by Maine Health as well. I am the coordinator for the Cleft Palate Clinic, and I'm also an NP in the Program for Children with Medical Complexity, which we'll be talking to you today about. And lastly is Jessica Rock. She's a registered nurse on our outpatient complex care team, and she's also our practice manager. So we're really happy today to talk to you about this topic, the collaboration between the inpatient and the outpatient teams for medically complex pediatric patients. Our objectives today are to identify the role of the inpatient complex care navigator, identify the purpose of our outpatient complex care program, and then talk about the utility of communication between inpatient and outpatient care management teams for these medically complex pediatric patients. We have no disclosures today. So before we get into what our programs are and how we interact, we thought we'd start with identifying who our patients are. So these are some pictures of kids that we might see in our clinic. So these are all kids that are using medical technology. So a baby with a G-tube, this little cutie with a trach and a ventilator, and this boy on the end who is using some adaptive mobility equipment. As far as defining who complex pediatric patients are, this is tricky because there isn't one set definition in the literature, but this was a pretty good definition that we pulled from a journal. Children and adolescents who have or are at an increased risk for chronic physical, developmental, emotional, or behavioral conditions and require health services beyond that required by the general pediatric population. So that's sort of the take home there. So this is another pictorial to demonstrate who our patient population is. So this was a picture that I took from a journal that it was drawn by a parent of a child with medical complexity, and it was so striking that the author included it in the research paper. So you can see at the enter, G is the child that this parent is describing, surrounded immediately by family as the center of that child's world. And then everything else is a branch of that that aspect. Every other branch is an aspect of that child's care. So everything to do with that child's health, their development, school, leadership and advocacy, recreation and community, and then support personnel. So I have kids, and a lot of you may have kids, and I look at this and I try to conceptualize this as far as how this would translate to my life. I do not have a child with medical complexity myself, and I certainly have these, school and health and recreation community, and that all feels like a lot to me. So adding all this extra stuff on the end seems almost impossible to be able to manage independently. So why do we care? So from a medical perspective, these are an extremely vulnerable group of children. While they account for 1% of all children, they make up to 40% of healthcare costs of children in the United States, and they account for over a quarter of all hospital days. From a caregiver perspective, these caregivers, parents, other guardians are spending an enormous amount of time providing care to their child, direct care, and coordinating their care and spending money on their care. The statistic at the bottom, 54% of family members stopped working to take care of their child, is really impactful. Of course, stopping working means stopping something that potentially brings someone a lot of joy or purpose and income. Again, from a medical perspective, these children are going to account for more than half of PICU admissions and use more than 75% of PICU resources. They have higher rates of unplanned readmissions, longer hospitalizations, they get sicker, their treatment plans are complex, and they have a lot of healthcare teams that sometimes can result in inconsistent care. Oop. Okay. So again, to drive home why these programs are needed, this is a wordy slide that I'll just sort of summarize. The number of children with medical complexity have grown over time, and this is because of advances in medical research and technology and therapies that allow us to save babies and allow children to live longer. Unfortunately, the systems that we have built in our communities haven't necessarily caught up. And so there's an unmet need to access care coordination. There's a lot of literature that supports that complex care programs can help to prevent hospitalizations, decrease length of stay, reduce ER usage, and improve coordination of care. So now I'm going to hand it over to Dana and Bonnie, who are going to talk a little bit about the inpatient side before we bring it all together.
Yeah, so as Amanda was just talking about, there is a huge inpatient utilization of care from the complex care population of these kiddos, and it takes a pretty big team in the hospital to take care of them. So our inpatient team is made up of quite a few different people. So we have inpatient hospitalists on both either the general inpatient unit or the PICU, registered nurses, RN care managers, who we have Bonnie here today, and then the complex care navigator, which is my role. We have social workers, ancillary team members, PT, OT, speech, dietitians, child life, all of our medical specialty consultants. So we have GI, Pulm, ENT, many others, and palliative care. And this is just kind of a small list. We could go on and on, continuing with all of the providers who help to take care of these kiddos in the hospital.
So I'm Bonnie. I'm the inpatient case manager here at Maine Health Maine Medical Center. So we service kids and provide care for kids from even prematurity all the way up to age 23. Although mostly focused on the under 18 population. We don't specialize in any particular system. So we see all the diversity of all the systems, whether it be GI, cardiology, neurology, all of them. So it's very diverse. And so I see my role as kind of getting them hooked up while they're here and getting medical stability. So they come into the hospital. Sometimes it's a planned procedure, and sometimes it's the worst day of their lives. Something has happened, or there have been changes in the patient's well-being that are really concerning, and they land on either our inpatient acute floor or in our PICU, and I service both those two units. And the first thing I do is sort of a screening and assessment. I start with some chart reviewing, and then I go and meet with the family and just have a really honest conversation. Often when they first come in, it's very overwhelming, and there are lots of providers in and out of the room. So it's kind of working on the timing. But once the timing and the window is open, I come in and I explain that I'm here to help you. There are going to be lots of people coming in. We're all trying to help you. But my goal is to get you to a place when it's time and it's appropriate and the patient is ready to get home safely. And to do that, I need to ask you some questions. And so I go on to ask them, what do you have already in place? The state of Maine has a lot of rural areas, and there are a lot of scarcity of resources, as we're seeing across the country. And so a lot of these families are on their own, and they're sort of regularly independent, and they've been managing their complex child for a long time. So I just ask, do you have any services? I think of 3 different domains. Do you have any in-home services? Do you have visiting nursing? Do you have block nursing? Do you have any, does the patient have any services at school, like PT, OT, nursing, speech therapy services? And then outpatient, does the patient have a case manager, behavioral health professionals that come into the home or provide outpatient services? And I just use that to gather information. Then I also ask about any special equipment. Do you have a nebulizer at home, any kind of respiratory support? How does the patient move around? What equipment do you have? What do you need? And this is where we find out sort of some of the holes in what their needs are. They may say, oh, I just carry him everywhere. I don't have any kind of DME to like get him where he needs to go. Or, I have oxygen at home, but I've been taping the nasal cannula because I don't get enough at home. So this is where I kind of pick up on all sort of the holes and what is happening, and also then communicating with the team to find out what the needs will be at discharge. Then that process goes on, and I continue to monitor progress towards discharge and attend family team meetings. This is where we kind of start looping in our complex care team. So if they qualify for the complex care team, they're coming to the team meetings as well, and we're discussing like what the needs are going to be. And I'm working with the doctors to make sure that the correct supplies are ordered, and the equipment that is needed is ordered, working and networking with all of our outpatient providers such as ADAPT, who spoke earlier on their services, and other services that we have in our community that provide equipment. And then making sure the patients have some confidence and some basic information about that equipment while they're here. I work very closely with Dana, who is the navigator, so that she can also do her part, and we can make sure there are no like gaps or holes and kind of keep that communication open. And then just looking for, what else would be beneficial to the family. And research has shown over and over again that having a discharge coordinator or case manager really improves health outcomes and like helps with continuity of care and decreasing length of stay, and helps the family feel more prepared. So that's where my role is. And I'm like, I'm all hands on deck when it comes to getting them ready for discharge and working through while they're getting medically stable. And then Dana gets kind of pulled into that next, so she'll speak to that.
Yeah, so my role is a newer role to the hospital that we started piloting a couple of years ago, and pretty soon we'll be finalizing this as a permanent position, which I'm very excited about. So we've called it the Complex Care Navigator. My role is really to support these complex patients and their families from admission through discharge, and making sure that they are feeling well supported, their needs are being met. All education that's necessary has been given. I serve as kind of the liaison between the family and the medical providers. These kids have such a huge team taking care of them in the hospital, often seeing them at different times during the day or the week. These kids are often here for prolonged periods of time. So communication between all of those teams can be really challenging. So my role is to serve as sort of that point person who stays in touch with all of the members of the team. I'll coordinate care team meetings if needed, to get everybody into one room. I try to facilitate communication between all of those specialties and the family to make sure that they're feeling that everyone is on the same page with the care for their child. I also advocate for the patient and family needs. So if they do feel like something that they're concerned about is not being heard, my role is to really advocate for that and make sure that they are getting to the root of their concerns with their child. I also, as I said, do a lot of the education. So prior to discharge, I'll make sure that families are fully educated on everything they need. A lot of our kids will go home with new technologies than they came in with, and it can be extremely overwhelming for them. And when they have, a new team or a new nurse each day, it can be a little bit hard to know where those education and knowledge gaps are. So I serve as that continuity throughout their hospitalization to make sure that all of the education that they need to safely go home with their child is met. And then I also liaison with the outpatient complex care team, which we'll begin to talk more about, to make sure that as kids are leaving the hospital, this great plan that we've created doesn't just end there, to make sure that there's no gaps when they leave their team in the hospital and transition back out to their outpatient team. I'll hand it back over to Amanda to go through what the outpatient complex care program is all about.
All right, so since our outpatient program is new, I'm just going to talk to you a little bit about how this came to be. So probably around 2021, the pediatrics administrative department at Maine Medical Center brought together a group of people with vested interest in children with medical complexity. So these were social workers and pediatric specialists and primary care providers. And we brought in one physician who was involved in the complex care program at the Hospital for Sick Children in Toronto to talk about what it would look like to have a program. We navigated some research. And one of the things that we talked about was doing a gap analysis with parents of children, with the parents of children with medical complexity in our local area. So we developed a qualitative research study. So that was done by myself and the pediatrician from our team, Dr. Logan Murray, and Danielle Doctor, who was a pediatric resident at the time, and she's now an attending pediatric hospitalist at Maine Health. We developed this study with the background that we knew that children with medical complexity have a high risk of adverse outcomes and a high cost of utilization. And we knew that complex care clinics have reduced costs and improved patient outcomes. And so we wanted to evaluate the current gaps and barriers that were faced by children with medical complexity and what we called a largely rural catchment area, which was children in Maine and our bordering New Hampshire families, and to understand what the families value in their care. So we interviewed about, I think it was 20 families that we reached in structured interviews, and we recorded these and we analyzed the results. And there was a lot of themes that emerged about the importance of compassion, how the use of telehealth was really helpful for these families, how communication styles really impacted how they experience their care, and the importance of structured care plans. We had a ton of great quotes that came out of these interviews, but this one was sort of striking because it really gave a good picture of what this person's life was like. So I'm going to read this quote. At this point in my life, I've been the parent of a medically complex child for approximately 10 years. It's difficult for me to know where me, myself, as an individual person ends and where my child with complex needs begins, because we're so closely tied in our needs and our challenges. We're living a shared life. And so for providers to really have a little bit of understanding when they're talking with a parent about their complex child, I think is good too. So this quote really provided a picture of this parent's life being really largely centered around their child. So amongst all this research, in the summer of 2022, our program manager from the Department of Pediatrics decided that we should stop all these Zoom meetings that we were having and have an in-person. I think it was like a 4-hour long meeting. I was like, there's no way we're going to get this many people together for 4 hours in the middle of the week, but she did it. So we had a meeting that had pediatric specialists and primary care providers and social workers and hospitalists and pediatric intensivists. And we did have, I believe, 2 parents as well as part of this session. And we all got together to talk about what was our vision and our mission, what were our goals, what was the current state, what was the ideal state. And out of that meeting, we were able to put together what our vision and mission would be for this program. So our vision was to provide highly coordinated, quality, family-centered care to help each child maximize their potential. And our mission was that our program would be a multidisciplinary team that provides evidence-based, comprehensive medical care with cultural humility and responsiveness to children with medical complexity throughout our communities in Maine and New Hampshire. We keep the families at the center of our work by facilitating communication, addressing barriers to care, and decreasing caregiver burden. No, I will say that there are different models of care for complex care programs. One model is a primary care centered model, which is a complex care program that is also the patient's medical home or primary care office. There's a consultative model, which is the model that we've adapted, and it's more of a adjunct, pediatric or specialist type addition to the patient's care team. And then there is episode-based model, which is more reactive. So maybe someone has a lengthy hospitalization and they follow up with a complex care team after that, or they have a planned procedure and they meet with a pediatric complex care provider to make sure that they're ready for surgery or to optimize their care prior to a procedure. Oops. Back. So we, as I mentioned in the previous slide, we did elect to develop our program as a consultative service. And the reason for that is because Maine is largely rural and our population is really spread out. The programs that offer more of the primary care centered model tend to be in urban areas where they're going to have a lot of patients who can access that program and live nearby and access that program as their primary care providers. But because we wanted to be able to provide this service for children all over the state of Maine, being a primary care office was not going to be efficient. Their patients weren't going to be able to access us for day-to-day acute needs. So we are a consultative service, and we started seeing patients in August of 2023. So we consider ourselves an adjunct to primary care for these patients. And for the purpose of our program, in order to be able to have some criteria for patients that can be referred to us, we consider our patients complex if they are under the care of 3 or more pediatric subspecialists for chronic medical conditions and or have use of medical technology. So G-tubes, vents, trachs, baclofen pumps, that kind of thing. So we provide coordination of care, connection to resources. We provide a comprehensive overview summary of that child's care that we update at each visit. And we also do management of G-tube feeds for patients that don't need to see a gastroenterologist because they don't have a GI diagnosis. Their G-tube feeds aren't related to any GI needs, which has helped to offload some of those patients from the GI service and open up their availability to patients who need to see them. So our team consists of a pediatrician, 2 nurse practitioners, 2 registered nurses, a dietitian, a medical assistant, and a patient service representative. So now we're going to talk to you about bringing our teams together.
Yeah, so one of the really exciting things that has come out of both the inpatient program building and the outpatient complex care program is our work together and how that has really benefited these very complex patients. So some of the things we do to work together to make sure that we have seamless transitions in patient care is to have biweekly meetings with members of everyone speaking today, along with a couple of our other colleagues. We meet and discuss patient care. We talk about the patients who are currently inpatient, we talk about if they have any needs or follow-up care that was planned as an outpatient. Say we have a patient who happened to get admitted for something, but they needed follow-up labs for an endocrine disorder that may not necessarily be related to their reason for admission. We can plan to get those labs while they're in the hospital already as part of other labs that we're getting, so that we can save them a trip to the lab as an outpatient. Same with if the outpatient clinic knows of a patient who may be getting admitted the following week for a planned procedure, they can let us know and we can be well prepared for them when they present for that admission. We collaborated together to create flags for the patient's chart that alert the inpatient and ED teams or anyone using the medical record really to some of the patient's unique needs. We were finding this population has really critical parts of their care that teams need to know before they start to provide that care. And there wasn't a great way to communicate that. So our teams working together were able to solve that problem and create a flag that pops up when anyone opens their medical record. We also work together when patients are admitted and we're gearing up for discharge. So I think this is one of the ways that we've really helped to bridge some of these inpatient to outpatient gaps. So we'll often have discharge planning meetings for weeks in advance prior to a complex patient getting discharged, especially if they're leaving with new technology, such as a trach and a vent. So the outpatient team will attend these meetings and be fully up to speed on the patient's care and be able to have input into planning for discharge prior to the patient leaving the hospital. And then when they do leave the hospital, they have a team outpatient who's already been involved, knows them really well, knows what some of the challenges are, knows the plan of care. And that's really, really helped a lot of our patients and families at home. And then they're also outpatient folks are coming in to see our inpatients for both new consultations and also for existing patients, which has really helped our inpatient teams caring for these kids who may be meeting them for the first time or only taking care of them for a couple of days before going off service. And we have this amazing team of outpatient providers who are now able to come into the hospital to see them and provide consults on them who know them really well. So these are all some of the ways that we've worked together to really enhance the care that we're able to provide for these very complex children.
So now we're going to present some cases to show you how we've worked together.
Yeah, so this first case that we're going to review is a little guy who was one of our first cases that we worked together as inpatient and outpatient teams. We learned a lot while working on this case that we've been able to use going forward with other patients. And it just really showed how the development of these complex care programs can benefit our patients. So this little kiddo was born at 37 weeks, had a very prolonged NICU stay, had spent some time in Boston where ultimately he ended up getting a tracheostomy, and he ended up with a G-tube as well. He had a lot of complex medical needs, obviously, but in addition, he had a lot of psychosocial stressors in this family that made his care challenging. There were language barriers, and actually both parents spoke different languages. So we were working within 3 different languages with 2 interpreters at a time. There's different cultural barriers to care that we had to navigate, housing instability, transportation challenges, financial challenges. There was a lot of both medical and social complexity with this case. And this kiddo had spent a lot of time in the NICU, and then ultimately they just struggled to find a safe discharge plan for this kiddo. The family wanted to take him home, but we just couldn't put all of the pieces in place to make that happen. So around 9 months old, he had sort of outgrown the NICU at that point and was transferred down to the general inpatient unit. And we had just recently put some of these complex care programs into practice. So he was one of the first kids that I was able to follow for a prolonged period of time as the complex care navigator. And then I worked very closely with Bonnie as well with this case to try to see if we could put all of the pieces together to make a discharge plan happen for this kiddo. So I don't know if you want to talk a little bit about some of the case management barriers.
Sure.
Do you guys need the next slide? Or we're still in that one?
Oh,
There
yeah,
we go.
go there.
Yeah, so this case was really an interesting case, and it was a great opportunity to start working with the complex care team and with Dana, the complex care navigator. I don't think this case would have worked out as well as it had if we hadn't had a team approach with multiple providers, like as a inpatient case manager. Really, the follow through outpatient and the education while he was here from the navigator was, just invaluable. There were a lot of challenges in terms of finding home care companies. There were lots of delays. One company had accepted and everything was moving forward, but had some concerns because of some of the language barriers. And when they met with the family, there was a lot of kind of complication and confusion, and they were hesitant to take on the family and then withdrew. And so we had to withdraw that authorization and get a new authorization with a brand new company and start over. So there were lots of those type of situations where we thought we were moving in the direction, and then we had to like make adjustments and changes. This is where the weekly meetings really came into play. So as we started setting up all these services and DME companies and providing education, and Dana was working with the bedside nurses to make sure that there weren't gaps in education. We needed to make sure that okay, this child's now medically stable, doesn't really require inpatient hospitalization, but we need to get them from here to being at home and being safe. So we started having these weekly meetings where we pulled in the outpatient team, and Jessica from the complex care was coming to those meetings so that she was aware of what steps we had already taken, so she could take off where we kind of left off. And so it was one of the really great first, I would consider, successes of the program in terms of all of us taking a piece of it and then working together to fill in all the places that we can't all individually meet.
Yeah, and I think we learned some really important lessons from this case. One of them was how beneficial the continuity and consistency and trust building and rapport building is with these families, because we were able to use that consistency and relationship building to more specifically identify the barriers that were a little confusing earlier on in the case. And we were able to build trust with the family so that we could fully educate them on the things that they needed to know. And once we had built that trust and rapport, it felt like things fell into place so much more easily, with getting them all of the training and the education that they needed. The benefits of the interdisciplinary meetings were also huge, getting everyone into one room at the same time, with the correct interpreters so that everyone was on the same page. And these meetings often included the physical therapists, occupational therapists. It included a lot of outpatient providers, so outpatient home care in addition to outpatient complex care, having everyone kind of on the same page to have the same, working towards the same plan to get this kiddo home. And he was able to be discharged. We were able to put all of the pieces together through these teams and the continuity and the teamwork, put all the pieces together. And just before his first birthday, he was able to be discharged home. And he's now thriving at home. He hasn't had any long-term hospitalizations, thanks to the amazing work of the outpatient complex care team. So I don't know if, Jess, if you want to speak to that a little bit, of just communication with family once they were home in order to help keep them out of the hospital.
Yeah, it's funny because we haven't seen him. I mean, we've seen him in follow-up, but we just haven't heard. I haven't even heard from this family for quite some time. But I think that one of my greatest roles, working as a nurse as well as the practice manager, has been giving these families somebody that they can call that they know of in the transition from home to from hospital to home, and also being able to coordinate still having that tie to the inpatient, to Dana, to Bonnie, to understand, once we see gaps, kind of where they left off, if it was little tiny pieces that were kind of left, to help the family with, and really work closely with case management, and and companies, just to get the families what they need. I think that was huge, especially with a family that just had such a, language barrier. Um, this is
I could talk a little bit about this. So he ultimately came home and he
okay.
was 11
Yes.
months of age, as Dana just mentioned. And he, like she said, is healthy and thriving, as much as he can be. So we had a lot of close follow-ups with he and his family in our clinic. He's had a few cancellations here and there, but he hasn't had any no-shows, which is pretty remarkable in healthcare, especially for a family with a language barrier and transportation issues. We've developed, I think, a pretty good rapport with this family. And one thing that we've done is always ensure that the family has transportation prior to the visit. And I think we know, like any of us can just say, like, we know that dad has the car. So if dad's at work, then mom's going to need transportation to get to the appointment. So we help the family with that and anticipate their needs. There was one hiccup when they got home. There was a home care nurse that called CPS because they were concerned about a parent not responding to what she thought was a medical event for the child soon enough. But we didn't really think it was an issue, and ultimately it was dismissed, and we've had no issues since, and that was probably over a year ago at this point. Jess has not heard from this family in a while because he is doing quite well. I did see him in the office recently, and he's doing great. They're actually looking at decannulating him soon, potentially. He was supposed to have airway reconstruction surgery last year, and he just wasn't ready for it, as it turned out. And the family was kind of upset, and they didn't understand why. But I really sat down with them and talked to them why it wasn't, why the surgeon had decided that it wasn't the right time. We took, a long visit to go over this, and why he was going to have to wait another year before it was considered again, because the surgeon does not do airway reconstruction surgery in the winter because of the risk for increased risk for viruses in the wintertime, impacting the patient's recovery. So they're going to have to wait until this summer, but he's doing quite well and might not need the surgery after all. So exciting things ahead for him. But yeah, when he first came home, there was a lot of issues with vomiting and sometimes fevers. And so the family would call Jess, and Jess knew this child really well. And a lot of times his vomiting, she knew, was attributed to constipation, and she walked them through probably multiple cleanouts and saved him visits to um, acute visits, and even ER visits by being a part of the team. So I think this is a patient you're going to talk about, Jess.
Yeah, this kind of leads us into our second case review, which I think is, a good one, but also, we learned some lessons from his discharge, from the previous patient's discharge into this one, and learned even more, which has been even probably more life-changing for the families ahead of him. But this little boy is now a 35-month-old child who has a complicated medical history of extreme prematurity, congenital chromosomal abnormality, um, bronchopulmonary dysplasia, tracheomalacia, chronic respiratory failure with trach and ventilator dependence, communicating hydrocephalus, pseudopapilledema, which has kind of been, and his protein losing enteropathy are all things that kind of came a little bit later. But admission to NICU at day of life of 0, transferred to Boston Children's at day of life 204, then transferred back to Main Med at day 448, and was finally discharged from PICU to home on 5/28. So length of stay between hospitals was about 707 days. There were multiple team meetings with this, I know, with the inpatient staff, trying to get everything together, multiple meetings with the family. Those meetings all kind of came together, as Dana had spoken about earlier. Dana, please jump in if I'm not getting this right, though. But Dana put together an entire booklet of all of this patient's DME companies, the other vendors, doctors, medications, anything that we could think of that they or she could think of that the family might potentially not remember or need to have handy in front of them. The other thing is, I don't know if this one or somebody else I'm thinking of, I don't know if the PCP was, I don't think the PCP was necessarily involved. Another similar patient ahead of him, or after him, sorry, we ended up looping in the PCP, which proved to be helpful too as well.
I think that's one
Which
of
I
the
think,
things we learned from this
yeah.
case is it's also really helpful to have the primary care physician at these discharge planning meetings. And that is something we've done moving forward for other kids.
So at our handoff, Dana said to me, he's ready to go, and I just want to get him home and keep him alive for at least one full night before he's going to have to come back. And we all had no idea how long this child would live, how well he would do at home. There was just so many components to his care, and at that point, I don't know if he had home health in place. I don't think he did. So he was home until readmission in August of the same year, which is longer than anybody thought he would be there, which resulted in a lengthy stay between MMC and BCH. But that was also because they had found this protein losing, they had identified the protein losing enteropathy, and ended up switching his G tube to GJ tube, I think, at that time. But anyways, he has remained out of the hospital with very short visits since December of 24. I think is there one more slide? So contributing to the success, I think I've talked a little bit about it. The weekly interdisciplinary team meetings run by Dana and anybody else that needed to be part of that meeting, including therapists, dietitians, social work, home care companies. I know the ventilator vendors were very involved in this kiddo. The binder, like I talked about, the ambulatory complex care team, we were involved in those meetings, prepared to take over coordination, preventing gaps and fragmentation of care. I think we learned a lot with this case as well. You know, working with this family, and one of the biggest things that we were able to identify after this family had left, and as we have with many other families, is that the equipment that is in the hospital and the speed at which they can get it is very different from that of the outpatient setting. There's many, tapes and gadgets for tubes that help secure tubes are just not as easy to come by, and sometimes aren't even covered by insurance. So it's identifying these and starting to educate the parents that although this is how it is, it's going to be different in the outpatient setting. And I think preparing them for that so that they are aware, rather than meeting that frustration of realizing it after they're home and running out of things that they might have gotten from the hospital. One of the biggest roles in my job personally is serving as the first point of contact for these families, for this family especially, as well as many others. They are very unsure of who to call, and that's often what I say when we get referrals to our program is they've got so many people involved that sometimes they won't even pick up the phone and call or show up to an appointment because it's too overwhelming, or they don't know what to do. So I always tell parents and empower them that they can call me, and even if it's not me, we are usually pretty well connected with all of their specialists. So being able to reach out to them pretty immediately and just kind of find out where it needs to go, or if it needs to go to multiple different providers because it's a multidisciplinary problem. Getting all the hands that need to be involved quickly is important, and then calling them back with the answer or the plan rather than them having to search for the answers and continue to tell their story over and over again. And then coordination by the I think there was a couple times actually that this particular family, I think, was once, but very, very well known to PICU, obviously. But we were able to, when he was coming into the hospital, we were able to coordinate a direct PICU admission, and avoiding the ED and just getting them to where we ultimately knew that they were going to need to go, which felt amazing for the family to not have to feel leery of people in the emergency room not knowing their child, and having to tell their story over and over again.
So I see we have like a minute left.
Sorry.
So
Okay.
no, it's fine. We just we're talking a lot. We weren't quite sure like how long we were going to take to talk. So we have a couple more cases that I'll just like skip over here. This was a medically complex patient that Dana worked with to make sure that they got home safely. And would be that mom would actually even be willing to take him home. When he got home, mom still had concerns, and I was able to organize a very robust multidisciplinary meeting that has helped him remain out of the hospital for a year now, which has been great. And then another patient who, this is one that's actually is back and forth to the hospital a lot, probably of all the patients that we've talked about, because she has a central line. And when she gets a fever, she's a kid that goes to daycare and she's going to get fevers, but we have to sort out whether or not it's related to a potential sepsis because of her central line. So she is back and forth a lot, but fortunately we're able to keep her hospitalizations pretty short as we possibly can when she does come in. And so looking ahead, did you want to do these slides, Jess, or you want me to go through?
I can do them. So looking ahead, we've identified through these different cases, we've definitely started to identify some areas of opportunity given what's worked and what hasn't necessarily worked, but we're hoping to expand the inpatient complex care navigator role into the NICU. So very similar to Dana's role and what she's doing and helping that bridge that gap between inpatient care in the NICU and discharge into the ambulatory setting. Seeking data to support the reduction in ER visits and decrease in hospital stays, which we're doing by providing telephone triage, first point of contact, and also consulting with the inpatient team with our kids that go in there and getting them out of the hospital, and having everything in place with a safety plan when they get out often decreases the hospital stay as well. Inpatient consults for current patients that are admitted, like I just said, not necessarily the new consults, but that way we can identify, having known what they're currently getting, we can work with Dana and Bonnie to make sure that that's all going to continue and that they have what they need as they move on, and then the follow up with us. A young adult clinic, we're seeing a lot of 18-year-old referrals coming to us with PCPs looking for help with the transition of care from adult pediatric to adult with multiple specialists. We hope to eventually have a better understanding and ability to a capacity to help these patients get to where they need to go. Eventually, we'd like a social worker. That's kind of been on our list for a while to help with a lot of this care management. And then a co-location. We're currently in Kennebunk, and we also see patients in Scarborough, but we are hoping to eventually get back to a very big castle somewhere where all the pediatric specialties can be housed for
I call it
more.
the magical unicorn building that
Yes,
doesn't
that's
exist,
right.
but we hope to have someday.
We hope to one day have that.
So sorry, went over time a little bit. Here are our references. This is our contact info, which I think is in the handout that everyone should have gotten. And I don't know if we have time for questions, but we're happy to take them if anyone has a minute.
Hi, just 2 seconds. Let's see. I think it's just recognition of the excellence of your presentation, and yeah,